alongside with the WFNS Neurosurgical Society and Young Neurosurgery Forum and Neurosurgery Couch, Pakistan Society of Neurosurgeons. And today we have Dr. Abdulghani Nasher. He is the chairperson of today's session. He is consultant neurosurgeon and assistant professor of neurosurgery at Sana'a University and one of the executive committee of the Yemeni Neurosurgical Societies. He will join us later. And today moderators is Dr. Ahmad Sharafuddin, head of department of neurosurgery at the Tara Hospital and the assistant professor of neurosurgery at Sana'a University. Dr. Ahmad,
Yes, doctor.
please you can go on and introduce our speaker.
Welcome, everyone. We have to welcome Dr. Yaser Khebar, consultant neurosurgeon, Hashim Medical City Hospital.
Thank you very much.
Our lecture today about osteoporotic spine, etiology, surgical consideration, fixation, and fusion option techniques. Welcome, Dr. Yaser.
Thank you. Thank you very much, Dr. Ahmed. So should I start then?
Yes, we have to start.
Okay, sure. So today we are going to be talking about the osteoporotic spine and the surgical outcomes and complications that we usually encounter when we deal with the osteoporotic spine as spine surgeons. I'm Dr. Yaser, as already mentioned by Dr. Ahmed. I'm a consultant spinal neurosurgeon in Hashim. So why osteoporosis matters? It matters because almost 200 million people are affected worldwide. Most of them are the elderly population, and there's a high incidence of spinal degeneration. This particular disease also leads to the failure of the implants, junctional kyphosis, pseudoarthrosis, and sometimes requires revision surgery. So this is the topic that needs mentioning in our discussion so that our young trainees are aware about the osteoporosis and the complications or the difficulties that we usually encounter when we are managing this kind of a spine. Worldwide, it causes more than 8. Yes, worldwide it causes more than 8.9 million fractures annually. Most of them affect patients who are 65 years and older. Both non-surgical, surgical options are there, but it depends that what kind of condition we are dealing with. So first of all, about the bone biology of the osteoporotic spine. See, in the normal remodeling of the bone, there are cells called osteoblasts will lead to the bone formation. And then there are cells which are osteoclasts will lead to the resorption of the bone. In osteoporosis, this resorption exceeds the formation, leading to the degeneration of the bone, and hence the bone is very brittle. And in such brittle bone, it's very difficult to do spinal surgery. Like whenever we are doing screw fixation in these patients, we do not get good grip, good strength, and this leads to the failure of the implant. Etiology. This can be primary osteoporosis or it can be secondary to some other conditions. Primary mostly in the senile population. As the patients turn old, obviously their bones become weak, brittle, the calcium intake of the patients is not up to the mark. The second cause is postmenopausal. As the females go postmenopausal, their estrogen amount decreases, and this lack of estrogen leads to the decreased ability of the bone formation. Hence, these are the two primary causes of the osteoporosis. Whereas secondary, we know many patients and usually physicians put patients on their steroids. There are patients who suffer from chronic kidney disease, hence lack of formation of the vitamin D, diabetes, states associated with hyperparathyroidism, overall vitamin D deficiency. In my country, the vitamin D is one of the most common factors and mostly deficient in most of the people. Again, then smoking, malignancy itself, which releases the parathyroid hormone-related peptide, will lead to the resorption of the bone and immobility in the old age. All of these factors contribute and lead to the osteoporosis of the bone. Most osteoporosis cases affect either the hip joint or the spine. So the two primary targets of the osteoporosis that usually are encountered in the old age is either the hip patient presents with a fracture of the neck of the femur or the hip bone, which we are not dealing with, and then the spine, which we usually deal. So what is the pathophysiology behind this osteoporosis? There's trabecular thinning leading to the loss of the connective tissue. Hence, there is a reduced pedicle screw purchase, and hence leading to the construct failure. So in this picture, you can very well see that it's showing a normal bone, and then it's showing a bone which is osteopenic. It's reminded that osteopenia is not the same as osteoporosis. Osteoporosis is characterized by decreased bone mineral density as well as the bone microstructure. So you can see in the third picture, the bone mineral density is reduced, and you can see that within the trabecular portion of bone, there are large holes being present. So in a normal bone, you can see how compact trabecular portion of the bone is. Very small porous structures are there, but most of it is occupied by the bony matrix. Whereas in an osteoporotic bone, there's an abundant area of lack of this bony micro architecture leading to the decreased purchase. So I have put in this classification, which actually concerns a spine surgeon. This is the osteoporotic fracture classification system. And later on, we will be dealing with the treatment recommendations, which are based on this classification system. So we have got type 1, type 2, type 3 fractures. Then we have got type 4 and type 5 fracture. So in the type 1 fracture, there is no deformation of the vertebral body involved. There is just a vertebral body edema that can be identified either on an MRI stir imaging. This is usually not visible on the X-rays. So we can identify this on a basis of the MRI. So in the MRI, if there are signal changes present on the stir MRI, then we can label as OF type 1. Then when we come to the type 2, in the type 2, we have got deformation of one end plate without or with only minor involvement of the posterior wall. So when we are talking about type 2, we have to look at the posterior wall. As you can see in all these examples, the posterior wall is usually intact or less than 1.5 of the length of the posterior wall is usually involved, whereas only one end plate is involved in the type 2. When we label it as type 3, when there's deformation of one end plate along with the involvement of the posterior wall. So if one end plate is destructed like this one, along with a decrease in the size of the posterior wall as well, we label it as type 3. Then comes the type 4. The type 4 is when the both end plates are deformed with or without the involvement of the posterior end plate. So when both end plates are involved, we label it type 2. There's loss of the vertebral frame structure. The vertebral body is usually collapsed, and pincer type fracture can be present. In most cases, the patients which are presenting to us are usually in the type 3, 4, or 5. The type 1 is patients usually present with the back pain, very difficult to identify unless you see it on an stir imaging. But the patients classically present with us when they have severe pain, deformity present in the type 3, type 4 stages. Then the type 5. These are the injuries in which there is tension band failure in osteoporosis, injuries with signs of the distraction, rotation, or translation being present. These are the ones that usually require an attention of a neurospinal surgeon, in which our especially has to be involved because there is deformity being present, there is compression of the nerves being present. Hence, a neurosurgeon tends to get involved in these type 5 fractures. So there's this scoring system for the osteoporotic fractures on the basis of which we can determine whether we should go for surgery or conservative depending on the type of the osteoporotic fracture. So we have got the type 1, type 2, type 3, 4, and 5 on the top. We score them 2, 4, 6, 8, and 10. You can see that type 5 gets a score of 10, definitely is going to get surgery. Bone mineral density is another factor which determines T-score less than -3 gets a score of 1. That is osteoporosis being present. Ongoing fracture process, either the fracture has occurred, but on repeat imaging, is there any deformation being occurring? Like is the fracture getting more and more collapsed with time? if we are keeping the patient on a conservative management. Then how the pain is under control, what is his WFNS score, is there a neurological deficit or not? If the deficit is there, yes, then we get a score of 2. Mobilization with analgesic, is it possible or not? And how is the health status of the patient? Obviously, this osteoporosis tends to involve the patients who are usually in the late stages of the life, more than 60 years. So American Society of Anesthesiologists score more than 3. Dementia is present or not. Body mass index, is it less than 20 or not? Is the patient on nursing care or not? Does the patient need anticoagulation or not? So if the score is between 0 to 5, go for non-surgical. If it's 6, it's the surgeon's preference. More than 6 is the surgical management. Then again, depending on the type, the management, you see the one with the deformation, no deformation being present, only edema is present on the MRI state, go for non-surgical management, simple analgesic, physiotherapy, medical training. In the type 2, when one end plate is involved but posterior wall is good, that management is usually similar to the type 1. But as I previously mentioned, that most of the patients who present to us are usually in the type 3, 4, or 5th category. These are the patients who have the involvement of the posterior wall more than 1/5. They have got a loss of the vertebral frame structure, vertebral body collapse, or those injuries in which restriction or instability is present. So in the type 5, when the instability is present, this author recommends a long segment posterior fixation. Long segment because the bone is osteoporotic. If you fuse or fix short, then it tends to get you tend to get a failure. So you have to fix a long segment within the osteoporosis. In the type 3 and type 4, you can go for posterior instrumentation. You can additionally use the cement augmentation. Type 4, you can use either the cement augmentation or a long segment posterior. So what are the spine problems that occur when this osteoporosis is present? We tend to get compression fractures. When the compression fractures are there for a prolonged period, there is instability. We tend to get kyphosis. Usually in the dorsal spine, whenever there is osteoporotic fractures are present, patients tend to present with a kyphotic deformity. Then adjacent segment disease. Even if you fuse a patient who is suffering from osteoporosis, then the bones are not so good in strength. Even if you do a cement fixation, but you did not go for proper optimization of the patient, you can get an adjacent segment disease very easily. Degenerative scoliosis tends to occur in this patient. If there's a retropulsion of the bony fragment within the canal, you can get the canal stenosis. And obviously, the hardware loosening is the most common factor we encounter with the osteoporosis. So how do we diagnose? What should be our paradigm when we are approaching a patient with osteoporosis? I always tend to get a DEXA scan for these patients. So without DEXA, you don't know how much osteoporosis is present, and you have to decide that whether you need to optimize the patient first or you need to go for surgery. There are certain conditions with osteoporotic spine in which surgery is rapidly recommended. For example, a patient with osteoporotic fracture presents to your clinic with a deficit and he has got weakness in his limbs, then obviously you cannot wait for optimization as there is compression of the neural structures. But in other cases, if the patient tends to present with the pain, no significant neurodeficit is present, I would always recommend that optimization should come first. The bone quality should be improved, and only then should you go for surgery. Then another test is quantitative CT, trabecular bone scan, MRI, CT Hounsfield units. I find the CT Hounsfield unit concept very good. Why? Because usually whenever we are planning a patient for surgery, we tend to get the CT scan of the patient done. So on the CT scan, we have got all those latest softwares which tell us that in which portion of the bone, how much Hounsfield unit is usually present. So you can very easily, with the help of software, take your cursor to the area of the bone where you want to determine the Hounsfield unit and see that what is the Hounds. This is a simple scheme in which if the Hounsfield units are less than 110, you have to say that this patient is high risk and has got a significant neurodeficit. osteoporosis present. If they are, means that bone quality is really good, you are good to go. Then what is the medical optimization when we are dealing with this osteoporosis? I usually give vitamin D to like international units once a week, calcium supplements. Bisphosphonates have got a role, but the one thing that intrigues me the most is that teriparatide. This usually comes with the name of the Forteo. It's a modified form of the parathyroid hormone. And the recent research has shown that this specific teriparatide has got a very good role when we are dealing with spine, and has got a very good role in the spinal fusion as well. So what I do is that if the patient comes to me just with pain, there is no surgical emergency, and the patient can be optimized. I usually start optimizing the patient from the start. And I continue optimizing him at least for 1 month, 2 months period, depending on the patient's condition, and then I proceed for surgery. But there are instances in which the patients cannot wait, like when there is a deformity being present, like OF type 5, or a patient with a neurodeficit in type 3 or type 4. In these patients, you cannot go for optimization. You have to operate, you have to decompress them. So then the medical optimization comes along with surgery, should start once you have admitted the patient, and should continue even in the post-operative period for the coming 6 months, 7 months, even a year in some cases. So for teriparatide, I would also like to mention that I come from a country, Pakistan, where it's quite expensive for the patients. So what I do is I usually start with teriparatide, though its recommended duration is 12 months, and it's a subcutaneous injection. But then after a month or two, I shift on to the bisphosphonates weekly and then continue with it. So what is the effect of the medications of the fusion? Bisphosphonates usually prevent the loosening. They have got a neutral kind of role in the fusion. Teriparatide has got a very better fusion score, has got a better role in screw fixation as well. And then we have got romosozumab, which is a newly drug, still there's emerging evidence. When should you go for surgery? If there's a neurological deficit, if there's mechanical instability, and if you think that with prolonged period of time, this instability is going to increase, if there's a progressive deformity, if you have tried the conservative management for the pain and it has failed, or the pathological fractures are present. And what are the challenges we usually encounter? There's poor screw purchase, pull-out strength is reduced, hence the screws tend to pull out. If you're going for a fusion, obviously your end plates are not as good as in the normal spine. So your cage can subsidence within the normal bone, proximal junctional failure can occur, and a revision surgery can come. So what should be the principle? Principle should be, you should maximize the fixation as much as possible. There should be a long segment. Obviously, in every surgery depends on the patient. The surgery should always be tailored specific to that patient. And obviously here in osteoporosis, we usually deal with old age patients. So we have to maximize the fixation, keeping in view that how many levels are involved and how proximal and distal we need to go. But we have also to keep in mind the age of the patient and what prolonged kind of surgery would this specific patient tolerate. You have to distribute the loads, increase the construct stiffness. How can we increase the construct stiffness? We can use the larger diameter screws. We can use the longer length of the screws as much as possible. And we can use additional rods as well if required. Improve the fusion biology. How to improve the fusion biology? We can use grafts. These can be autografts or can be grafts like BMP can be used to improve the fusion of the patient. We can give teriparatide. So pedicle screw biomechanics. See, whenever we talk about pedicle screws, I might have put in a picture over here. So if you can see this picture, this is an example of a pedicle screw. Just don't look at what kind of a screw it is. In the pedicle screw, we have got these threads. And we all know that the distance between two threads is the pitch. And the distance between the two threads is the pitch. And this pitch actually determines that how good a pull-out strength of the screw is. So you can tailor the pitch of the screw to determine the strength of the pull-out, and then there's also the diameter of the screw that we are putting it. See, in osteoporosis, the surrounding trabecular bone is quite loose. So the larger diameter screws are more likely to hold rather than smaller diameter screws. So try to use as much longer diameter screw as possible. Another thing with the screw is how many cortical surfaces you are traversing. So then comes the concept of the bicortical purchase. So what is bicortical purchase is that you enter from one cortical surface, but normally what we spine surgeons used to do is we used to stop just short of the second cortical surface so that there is no anterior breach in a patient. But in the cases of the osteoporosis and even routinely, whenever you identify that bone quality is not so good, you should always aim for a bicortical purchase. A bicortical purchase will be such that you should not pierce in very much anteriorly. It should be minimal. But the goal of achieving a bicortical purchase is that there are two cortical surfaces that you are traversing. Hence, there's good pull-out strength whenever you do bicortical purchase. So this picture shows the example of that bicortical purchase. He is entering from one cortical surface is here, going through the pedicle, and then he just goes anterior to the anterior cortical surface, getting a bicortical purchase. So factors in the pedicle screw, there are factors affecting the pull-out. The diameter matters, the length matters. Also, how does the length matter for a screw? It depends how you are putting in a screw. If you put a screw straight in an ideal fashion, like parallel to the end plate, then the length is going to be short, obviously. But you can manipulate the direction in which you are putting in a screw specifically. You can put it in a downward direction, going from top to down. You can put another screw in an opposite direction. So using this different direction in different screws, like one screw is going down, another one is going straight, this actually increases the pull-out strength of the screw as well. So when we are dealing with these osteoporotic patients, when we need a good purchase, you can put screws in different directions so that there is good pull out during the surgery. So trajectory, yes, I just mentioned different trajectories for various screws. It can help. Then the thread design, we talked about the pitch previously. So another trajectory is cortical bone trajectory. Normally, the routine traditional pedicle screws that we put in are the pedicle screws that we put in there, usually the transpedicular screws. But then this is the newer concept of the cortical bone trajectory. This one has got a better cortical purchase, less dissection. It is useful in osteoporosis. And this is the picture which actually demonstrates it. When you're using a traditional pedicle screw, you enter from the top, go in. But in the cortical bone trajectory, you tend to remain and aim for the cortical portion of the bone. Like in this one, we are putting in the screws toward the superior end plate. So you see that cortical bone is usually around the edges or the margins of the bone. In the center, we have got this cancellous bone. The cortical bone is comparatively more strength-wise, it's more compact than the cancellous portion of the bone. So this is the example of the cortical bone trajectory in which the author has put in the screws in the cortical bone trajectory so that there's a good strength present. So here you can see one is in the traditional pedicle format, another one is put in the cortical bone trajectory. In this one, we previously talked about the bicortical fixation. So here he's using the cortical bone trajectory along with the bicortical fixation. See, usually the traditional pedicle screws tend to go from lateral, we move inside. But in the cortical bone trajectory, we have a more medial entry, and we tend to go laterally around the margin of the bone so that the screw usually remains within the cortical portion of the vertebral body. Okay, then there are different adjuncts which have been devised specifically for the patients that present with the osteoporosis. One example is of the expandable pedicle screw. In this type of pedicle screw, we have got this specific shaft with which we can expand the screw once it's placed. So you can see that the author is placed in the screw, and then with the help of this shaft, he has expanded the screw. What is the use of this expandable pedicle screws? That you go in and then you expand the screw within the bone substance. So now the pull-out strength would obviously be increased if you are going to expand it. The advantage is there's higher pull-out strength. They can be useful in revision. You have put in size 5.5 diameter screws in a vertebral body, but now if you go for another 5.5, it won't hold because there is a pull-out already present. The cavity has been increased. In these cases, they can be useful. Limitation is the cost, the difficulty in removing these screws. Then the second method that we use in the osteoporotic spine is the cement augmentation. We usually use the polymethyl methacrylate, PMMA. The advantage is that in osteoporotic spine, we have got an excellent fixation. It reduces the loosening. Disadvantage is that cement may leak in the adjacent bone. Obviously, we have got an osteoporotic bone. A cortical wall may not be intact or has been breached during the surgery. The cement may leak out. The cement can go within the vessel, leading to the pulmonary embolism. The cement sets with an exothermic reaction, so there can be thermal injury to the nervous structures. So how do we do this cement augmentation? We've got two methods to do cement augmentation. The ideal one is that now we have got a type of screw called fenestrated screw. In the fenestrated screws, we have got holes in the end, and we usually tend to inject the cement through the screw itself. But we can also use this technique that we go with an injector transpedicularly, put in cement first within an osteoporotic portion of the bone, and then place the screw later on within this bone. So we can, if the fenestrated screws are not available at your center, then you can utilize this technique that you go via an injector, augment like vertebroplasty, do cement augmentation of the vertebral body, and later on put screws within an augmented spine. Like this one, there's a thread cutter being put inside the vertebral body. You create a space, you inject the cement, and then you inject the screw. The other ideal method to deal with this is the fenestrated screw. So these are specially designed screws, as you can see in this picture. These screws have got these special holes inside them, and there's a hollow structure present. So you can, once you have inserted these screws, you can inject the cement directly through the screw, and then the cement comes to stick within the vertebral body around the screw. This method encourages the uniform distribution of the cement, and there's higher fixation because cement is going through the screw, and then within the vertebral body, it occupies the space around the screw. So this is an augmentation adapter which is being shown to put in the cement. And in this picture, you can see that the screws have been placed, and then they are cement augmented. The cement can be visualized within the vertebral body around the screws. So this is another example of the cement augmented screws. The cement is occupying the space around the vertebra, around the screws, hence increasing the pull-out strength. So the satellite rods. This is another concept in which we can use in osteoporotic spine to provide additional strength. This is not routinely used. The accessory rods can be held along with the primary rod. They can provide stability, but I'm not much in the favor of the satellite rods. Rather, the cement augmentation and the expandable screws or fenestrated screws tend to do well. When are they useful? When there's a 3-column osteotomy being done or a long construct is required, they can provide the additional reinforcement. Also, you can, if you are dealing with a lumbar spine, and in the lumbar spine, you can take additional help with the help of the sacroiliac screws. They provide much more powerful strength to your construct overall. They are helpful when you are doing long constructs in the osteoporotic bone. So interbody fusions, various techniques have been available. They have got advantages in osteoporosis over the time because they increase the fusion surface. They have a larger footprint, but obviously you have to take in mind the risk of subsidence in the osteoporotic patients. Because whenever we are going to place the cages within an osteoporotic patient, we need to be careful about the anatomy. We know that they can subsidence within the vertebral body itself. So what kind of cages are available? We started with simple bone chips, and over the time, we have developed more recent type of cages. Initially, we had PEEK. Now we have got the most latest 3D implanted cages, which are made of titanium, which are actually printed as per the patient's requirement as well. This is an example taken from the cervical spine. Though cervical spine osteoporosis tends to affect very less, but just for the example purposes, most of the osteoporosis cases that we encounter are usually within the dorsal spine or the lumbar spine. Fusion biology. Obviously, we have got various methods of increasing the fusion. My mentor always used to say, the fusion should be good. Your construct or the fixation that you do with the screws is not going to last long, but it is the fusion that you actually do during your surgery is what going to last long. For a good fusion, you need a good exposure of the bone surface. You need to provide a good graft along the transverse processes as well to get an inter-transverse fixation as well, or you can use interbody fixation as previously mentioned. We've got autografts, we've got allografts, we've got this BMP material, all of them can be helpful. Teriparatide, I previously mentioned, multiple RCTs prove it has got an improved fusion rate, reduces the screw loosening, and there's reduced risk of revision when we are using this material. Then in the end, I would also like to talk about the vertebral augmentation. So what is vertebral augmentation in the osteoporotic spine? There are two types of vertebral augmentation. One of them is kyphoplasty, another one is vertebroplasty. The difference between them is in the vertebroplasty, the aim is just to inject the cement percutaneously or in an open method under fluoroscopy. But in kyphoplasty, you tend to restore the kyphosis of the patient as well. So for example, if you have got a wedge compression fracture and you just put in a cement inside it, that's vertebroplasty. But if you want to align or increase the height of the vertebral body which is fractured, you want to increase the anterior height of that fractured body, then it's called kyphoplasty. For example, in this picture, you can see that this vertebral body is fractured anteriorly, and we go transpedicularly with the injector, put in the cement. This is called vertebroplasty. And in contrast, if you put in the same method, you go transpedicularly within the body, but here you can see that there's significant reduction in the size of the body. There's a kyphosis occurring, and now the goal is not only to put in and inject the cement, but your goal is also to restore the height of this collapsed vertebral body. Then it's called kyphoplasty. So again, there are various methods to achieve this kyphoplasty. One of them is balloon kyphoplasty, where you put in a balloon, you expand the balloon so that the height is restored. It creates a space within the vertebral body, and within that vertebral body space created inside the body, you can fill in the cement. So then there are various types of kyphoplasty. You've got radio frequency kyphoplasty. You have got a spine jack system. In the spine jack system, though the picture is very small, but actually a spine jack is introduced, and then just like we inflate the balloon, we open up this spine jack, which restores the height of the vertebral body, and once the height is restored, then we tend to put in the cement. So in this picture, you can see that first of all, we put in the implant. After implanting the spine jack, we expand the spine jack. Once it's expanded and the body height is restored, then we put in the cement. Then you have got coil VCF system, in which again the expansion is done with the help of the coils. And this one we previously discussed, the pedicle screws with the cement augmentation. So again, the vertebroplasty, kyphoplasty procedures are in separation. They are usually reserved for patients who present with the severe back pain after the osteoporotic fractures. So then there are various studies done which compare the vertebroplasty versus the placebo. Some studies say that vertebroplasty is superior. Most of them say there's no significant difference in the pain management. And then vertebral augmentation versus conservative management showed that the primary outcome improved with the vertebroplasty or the kyphoplasty, whatever you are doing. So these two procedures are usually reserved for those patients who tend to present with OF type 2 or type 3, who do not have a neurological deficit, but just have got a back pain, which is not improving with the medical management. So again, with augmentation, you have got risk factors as well. They are beneficial in acute painful fractures less than 6 weeks to achieve better pain, but there are complications like cement leakage in the vertebroplasty or progressive loss of the hind adjacent level fractures in the kyphoplasty. So overall, various complications that we do encounter are the loosening of the screws. There can be pseudoarthrosis in the osteoporotic spine. The rods can get fractured due to the increased load. Proximal junctional kyphosis can occur. Infection can occur. How do we prevent these things? You have to optimize the bone health, use longer screws, thicker screws. You can use cortical bone trajectory, cement. You can additionally provide an anterior support. WFNS recommendations, they recommend pre-operative assessment for the osteoporosis for all patients. You have to optimize the medical therapy. They deemed that teriparatide was beneficial. The augmentation should only be used selectively for the management of the pain in selective patients. And the longer constructs that you are putting in or you're going to put in require careful planning pre-operatively. So surgical algorithm should be to evaluate the osteoporosis first of all, then you optimize the patient medically, you determine if instability is present or not, then you choose the fixation, and then you continue the treatment post-op. Obviously, the medical optimization is deemed helpful only for those patients who are not presenting with a neurosurgical emergency. This does not apply to those patients who present with acute fractures leading to the cord compression. For example, I had a patient with a dorsal spine fracture. His body got collapsed. There was a sharp peak of the dorsal spine indenting the spinal cord, and I had to go for the surgery straight away. And I had to use cement as a backup. And then I had to manage him post-operatively by keeping him on the bed rest for some time and keeping him on the teriparatide and other vitamin D and calcium to optimize him. So the key message is that osteoporosis changes every surgical decision. Bone quality assessment is essential, either via DEXA or in routine via CT units. You have to optimize the bone health before surgery whenever it's possible. Augmented fixation, like with cement, or an additional anterior column support with the help of cages can improve the construct durability. Out of all the biological agents, the teriparatide has the strongest evidence for the fusion. You have to individualize the strategy based on every patient. Every patient is different. You have to look at his bone quality, his own pathology, and determine the best outcome for that patient. Ideally, for these patients, you should have a multidisciplinary approach. You should involve the local physician in your hospital who should or an endocrinologist who should optimize his bone quality and other things, and then you should go for surgery. Thank you. Thank you very much, Dr. Ahmed. This was all. I would like to take any questions at present.
Thank you very much, Dr. Yasser, for this nice presentation. Dr. Ahmed Sharifuddin and Dr. Abdulghani Nasher, please, if you have any comments.
Dr. Yaser Khebar.
Thank you, Dr. Yaser Khebar, for the nice presentation which you present for us. We are waiting if there is any question from the participant.
First of all, I would like to thank Dr. Yaser. You really open one of the most problem in spine surgeries, which is osteoporosis. As we know, the osteoporosis, I think it is a reversible problem. All what we can is to hold the problem or to help the patient how to minimize the suffering from this pathology. Osteoporotic spine is a help for any surgeon facing a patient with neurological deficit. So when you are choosing a surgical option for management of the surgical the pathology of patient, you have to consider the fail of surgery because of osteoporosis of other complication which could happen with the patient after surgery, especially if the patient is in old age, if he has a lot of systemic disease, low immunity, and heavy weight. All of this can, unfortunately, put you in hell after surgery. Thank you, Dr. Yasser, that you covered the things or the instruments what can surgeon use for the minimize this complication, kind of screws, such like expandable, cannulated, or techniques also. A lot of techniques you show us in this nice culture lecture. It minimize the complication after surgery. But if we can avoid the surgery in osteoporotic patients, if the patient it doesn't have an emergency or absolute indication for surgery, better to avoid. This is my opinion. Even if the patient can tolerate the pain and he doesn't have neurological deficit, also avoid the surgery. Even you can see a clear cause of pain, because the osteoporosis patients can carry a lot of problems after surgery. Thank you again. Also, I would like to hear from the participants their questions to you. And again, your lecture is very nice and cover one of the most problem in the surgery.
Thank you, Dr. Ahmed.
If I have a question, Dr. Yasser, in your practice, Dr. Yasser, when you optimize the medical treatment for patients with osteoporosis to optimize the bone health, what's the interval you use for follow-up usually?
I did not get you. What did you ask in optimization?
When you have a patient with osteoporosis and you need to optimize its bone health before surgery, you start giving bisphosphonate and vitamin D and calcium, yes or no? What is the period for follow-up you do until you check for the bone if it's optimized or not before surgical?
Yeah, see, if you ask me about how I deal with osteoporotic patients, is that I usually, if the patient is presenting only with the pain, I tend to delay the surgery as much as possible, because the pain can usually be managed medically. But if the patient is presenting with a deficit, like acute limb weakness or an acute cord compression, then it changes the scenario. Otherwise, if we are managing a patient in the medical optimization, we should start him on the vitamin D, calcium, bisphosphonates, and I think ideally we should wait for at least 3 months period and get a DEXA scan again to evaluate that whether the DEXA quality of the bone has improved or not, and then we should decide that how we should proceed. Osteoporosis is a very tricky concept whenever we are dealing with the spine. In osteoporosis, the construct tends to fail a lot. In my personal experience, I have operated on a patient who presented with a L1 or L2 fracture, and I fixed the patient, but it did not lead to the fixation or the resolution of the pain of the patient. Actually, the patient kept on suffering from the pain. And it is from our personal experiences that we learn. And I learned that the next time I'm not going to do it for the pain of. So now I usually keep it only for patients who have neurodeficits. And I tend to operate these patients, and then I keep them on a post-operative photio, and for at least a month or two because of the financial issues. And then I shift it to the bisphosphonate. The bisphosphonate I usually use is alendronate, and comes with the name of grade D. It's usually taken orally once a week. And I tend to keep the patient on this bisphosphonate at least for a period of 1 year, post-operatively as well. And if you are talking about the medical optimization in the pre-operative period, if the patient can wait from the surgery, then he should ideally be optimized for at least a 3-month period so that his bone gains adequate quality before going for surgery. Another thing is that there are patients who present with other spinal issues, like you can encounter a patient who has got L4-5 listhesis and is in severe pain due to the L4-5 listhesis, but he has got osteoporotic bone. You want to fix the patient for L4-5 listhesis, and he has got severe leg pain and everything, but then you go for his DEXA. You see his X-ray, the X-ray shows a reduced bone quality. You go for DEXA, DEXA shows that he is osteoporotic. Now you need to fix him to get him walking again, but he's osteoporotic as well. So in this specific scenario, I think I would ideally wait for a 3-month period of optimization, keep the patient on the pain management for belt, maybe on the painkillers, Z-Gab or etc. And then after a 3-month of optimization, I reassess him via a DEXA. I see if his bone quality has improved, and then I go and fix him. So this is what I would recommend. And there has been another incident with me in which I was operating on a patient. In this specific patient, there was L5S1 listhesis present. And I did not pick up his osteoporosis pre-operatively, but when I opened her up, I encountered osteoporosis. At that time, I had no cement available in my hospital, so I waited for 30 minutes. The cement came, and then the 3 screws were good. 1 screw was loose in the sacrum on one side, so I augmented it with the help of the cement, and then I fixed her. So in this specific patient, I kept her on bed rest for at least 2 to 3 weeks and mobilized her only with the help of the belt, kept her on post-operative photio, and she is now doing well, alhamdulillah, and she's mobilized, walking and everything. But for juniors or those who are just starting a spine surgery, I would say that always consider a DEXA scan in the patients whom you are going to fix who are above the age of the 60, because you don't know when you are going to encounter the osteoporosis intraoperatively. So DEXA should be a part of protocol. Thank you, Dr. Ahmed. Any other question?
Thank you for your answer. If anyone of the participants has a question, please you can ask in the chat or you can ask directly if you like.
Excuse me, Dr. Ahmed, I want to ask.
Go on, doctor.
Dr. Yaser, if we decide to do augmentation in patient with a neurological deficit, there is a risk for deterioration of for increase of neurological deficit.
Augmentation. I did not get you. Do you want to do augmentation in the neurodeficit, a patient who has presented with neurodeficit, or you're talking about post-operative neurodeficit?
I think he's
No,
asking about
patient present with neurodeficit.
See, augmentation is a procedure which, if we are talking about kyphoplasty, it restores the height of the vertebra. But these procedures mainly help relieving the pain. They are not actually decompressing the spine. So I would recommend that whenever the patient is presenting with a neurodeficit, you need to decompress the patient. Simple augmentation won't decompress the nerves themselves. Even if a patient has got a wedge compression fracture with the collapse or loss of the posterior wall, and posterior wall has retropulsed inside the canal. So if you expand the bone, that posterior wall which is compressing the nerves is not going to go away. So I think vertebroplasty, kyphoplasty are good procedures only for those patients who are not being managed medically for the pain. They are useful as adjuncts, like you are doing a decompression, you are doing a fixation. Now you want to augment the body with the cement. You can do vertebroplasty, then put in the screws. But for a patient who's presenting with a neurological deficit, I don't think a vertebroplasty, kyphoplasty alone would help. Maybe you can put further light on it. Thank you, Dr. Ahmed.
I think question was about vertebroplasty and kyphoplasty. After injection of bone cement, some patients may have a leak and have more canal stenosis and neurological deficit after injection of the bone cement.
Yes, this can
So
occur.
how you prevent this?
Yeah, if there is cement leakage within the canal, obviously the deficit could increase because the patient body tends to be osteoporotic, and the cement can leak within the canal itself. And if there is cement leakage within the canal, this can worsen the neurodeficit of the patient. Yes.
So how can you prevent this and manage it if it happens?
if it has happened, then we need to go and remove that cement. We have to open the patient up, decompress him if it happens, because obviously the cement would set in, and we have to open him up if the complication has occurred.
And how do you prevent that? How can I anticipate if this patient may had leak or no? If there is any signs or any radiological features to look out?
See, how to detect it on the radiology? That is what you're asking?
How I anticipate if this patient may had leak or no?
Depends on the level of the compression that you are dealing with, depends on the intactness of the posterior wall of the vertebral body as well. If a patient has got good intact posterior vertebral body wall on a CT, on an X-ray, then there's a less likely chance that it's going to leak. But if a patient has got a posterior wall involvement and posterior wall is already collapsed, there's a good chance that the cement can leak within the canal itself.
Thank you.
You can use, sometimes you can use a contrast before injection the cement. Sometimes, and you can predict sometimes if there is defect in the posterior wall. But the CT scan before surgery, before this procedure, of course, vertebroplasty and kyphoplasty is for pain, not for decompression or for management of the compression of the neurological structures. But the CT scan before surgery helps you to detect if there is defect in posterior wall. Also, sometime before surgery, you can, if you are very afraid of there is some defect in the wall, you can inject a contrast. If there is leak of contrast, I think you can avoid to inject the cement. Also, try to inject not fluid part of cement. Try to inject not hard and not fluid cement. And in between to be sure that the leakage is less cannot happen. Also, to be sure the depth of the needle, and when you are more anterior and more far away from the posterior wall, also I think very rare it happen. The leak could happen in this condition. Also, all the time make fluoroscopy check the anterior and posterior view during the injection of the cement. If you start to see the leakage, stop, don't remove the needle, and use the gravity also to prevent the leakage to not happen. And as Dr. Yaser said, start the compression immediately at the same time. Yes, Dr. Yaser?
Thank you, Dr. Abdullah. That was a very interesting point about the contrast. That would be really helpful in job. Thank you.
There is
Are there
no
any
more
other
questions.
questions, Dr. Ahmed, or is it okay?
I don't see any question from the participants. So, Dr. Abdulghani, you can say the finishing remarks for this session.
Well, I would like to thank everyone who has today attended us to this nice lecture. Really, it was very, very nice, very interested, and you remind every one of us how to deal with those osteoporosis patients, how to choose the beneficial way to help, and not to put patients in the help, to help the patient. You did good and big job. I think all of us will keep this lecture and will teach our students, our doctors also. This lecture will be one of the reference in osteoporosis. Thank you again, Dr. Yaser. Hope you and your colleagues very nice weekend, and hope I can meet you again. Thank you, Dr. Ahmed. Thank you, Dr. Ahmed Sharafdin, for your nice participation and nice information you have given.
Thank you very much, Dr. Ahmed, Dr. Sharafuddin, and Dr. Abdulghani Nasir Saab. Thank you. Thanks a lot.
I also want to thank you, Dr. Yasser, for this nice presentation, and thanks for your participation with our program. I think it's your fourth presentation now, yes?
Yes.
So you are one of the active participants of our program, and always we enjoy your presentations, and you give us valuable information. So thank you for your participation, and thanks for all
Sure.
attendance. Thanks for all attendees today, and thanks for Dr. Abdullah Nasher for chairing this session, and for Dr. Ahmed Sharifuddin for moderating the session also. And by this, if there is no any more questions, we can conclude today's session, and see you all inshallah next week.
Inshallah. Thank you.
Thank you.